Okay. Hello. Yeah. So we start with the cartilaginous joints, which are, primarily immovable joints. And as you can see, some examples of cartilaginous joints at different parts of the body. So you have the sternum, okay, the rib cage in the sternum, and there is the joint between the first rib and the sternum. So this connection point of the ribs with the sternum is actually an immovable joint. So there are also examples of immovable joint in the sort of the near the humeral head, as you can see, and also there is slightly movable joint, which actually means there is some movements allowed at this joint, but it is not entirely movable. Okay, so pubis symphysis, that is the joint where the two pelvic bones from two sides actually meet. This is a very important joint as far as the mechanics of pelvic bone is concerned. So this is known as pubic symphysis. Okay, so this is a connection point, a joint which is slightly movable. Actually, this joint consists of very strong cartilages, and they are actually trying to form a joint which is very slightly movable. The other slightly movable joints are shown in the vertebral column, as you can see, intervertebral discs, and you have the band of fibrocartilage. So in between the vertebra, you have the slightly movable joints. Now, freely movable joints, which are most common, and we will more focus our attention on these joints, are popularly known as synovial joints. Okay, and these joints actually provide you gross movement. Okay, so please note that the synovial joints are actually responsible for gross movement of the body. Okay, so the most movable type joints, as it has been marked here, and each contains a fluid. So each joint contains a fluid-filled joint cavity, which is shown in this figure A. You can see typically an example of two bones. Say, for example, you can take it. It's just an arbitrary sketch of a joint where you have two bones meeting, and then this joint is held together by ligaments, and at this location, at the joint location, articular zone, there is a joint capsule or joint cavity, and this, you can see, contains a fluid which is known as the synovial fluid. Okay, so all these freely movable joints are mostly synovial joints containing a joint cavity filled with synovial fluid. Now, synovial joints with articular discs. So some synovial joints actually contains an articular disc. So these are some exceptions. Okay, some synovial joints are actually having this articular disc. So this occurs in temporomandibular joint and at the knee joint. So temporomandibular joint is the joint which is formed by the mandible. Okay, so the jaw. So there is a temporomandibular joint which contains an articular disc, and also the knee joint that also contains an articular disc. Now, where is this articular disc? This is clearly shown in the figure, as you can see. Okay, so these actually occur in joints whose articular bones have somewhat different shapes. Okay, so this is actually present in bones which have slightly different shapes, somewhat different shapes. Now, I would now discuss the general structure of the synovial joints. So it has articular cartilages. It has articular cartilages on the ends of the opposing bones. So you can see here in the figure that at this ends it has an articular cartilage. That's the blue one in the figure. Okay, so articular cartilage at both the ends of the opposing bones. Okay, and the function of this articular cartilage is to actually, it absorbs compressive loads, so it absorbs compression, and it also takes into account some amount of impact loads. Joint cavity, as we often call it synovial cavity, is unique in the synovial joint. So all the synovial joints actually have a joint cavity, and this is what is the joint cavity. If you can see in the sorry, I have to go to that. Just a moment. Pointer, laser pointer. So you can see the joint cavity. This is the joint cavity, and this joint cavity actually contains the synovial fluid. So this is unique to the synovial joint, and the cavity is a potential space that holds a small amount of fluid. So this fluid actually helps in lubricating the joint to a great extent. So it reduces wear, it actually acts as a lubricant, and it can also take compression load as well as impact load. So together with the articular cartilage and the synovial cavity containing the fluid, these synovial joints actually is responsible for sharing of load as well as offering a large range of motion. Okay, so clearly if you visit the slides again and again, you will find the descriptions of these bony parts, the joints, the inside part of the joint, as well as the joint cavity very clearly. Now, more about the general structure of the synovial joints. So you have articular capsule. We are moving inside, slowly focusing more inside the joint capsule. So the articular capsule, the joint cavity, is enclosed in a two-layered, you can see in a two-layered capsule. So there's a fibrous capsule, which is dense, irregular connective tissue, and it strengthens the joint. Okay, so there is a structure and there is a function of each constituent element of the synovial joint. And there's a synovial membrane, which is a loose connective tissue. Okay, so you have a synovial membrane and you have a fibrous capsule. You see the fibrous capsule here very clearly. And the synovial membrane is the green one, which is at the inside surface of the fibrous capsule. The synovial membrane is a loose connective tissue. It lines the joint capsule and covers the internal joint surfaces. Basically functions to make synovial fluid. So the synovial membrane keeps on generating synovial fluids. Okay. Now, what is this synovial fluid? It's a viscous fluid similar to raw egg white. Okay. So it is similar to raw egg white, and it's a viscous fluid. A filtrate of blood arises from the capillaries in the synovial membrane. So this is a little bit. So it arises from the capillaries in the synovial membrane, and it contains glycoprotein molecules secreted by fibroblasts. So fibroblasts are sort of cells that actually are responsible for fibrous tissue, for generation of fibrous tissue, and this actually synovial fluid contains glycoprotein molecules secreted by the fibroblasts. Now, the synovial joint has reinforcing ligaments. Okay, so it has reinforcing ligaments on the two sides, so which actually holds the capsule, joint capsule in place. So often are thickened parts of these reinforcement ligaments often have thickened parts of the fibrous capsule. Sometimes are extracapsular ligaments located outside the capsule. So you can see here the ligaments, very clearly the ligaments that are holding the synovial joint or the joint capsule in place. And they are sometimes extracapsular ligaments, sometimes they are intracapsular, located internal to the capsule. So one is extracapsular, which is located outside the capsule, and intracapsular ligaments, which are located internal to the capsule. But generally, reinforcing ligaments are there to hold the joint capsule in space. This sort of synovial joints are richly supplied with sensory nerves. Okay, so there are nerves which can detect pain. They are very sensitive, and they can detect pain very easily, and most monitor how much the capsule is being stretched. Okay, there's some words which actually have gone behind the picture. Might consider changing it a bit. Just a moment. Yeah. So the synovial joints are also richly supplied with blood. So they have a rich blood supply. So most supply the synovial membrane. So the blood supply is at the synovial membrane, and from the membrane it goes inside. So extensive capillary beds produce various bases of synovial fluid. So there is extensive capillary beds which actually produce a lot of synovial fluid, keeps on generating synovial fluid and lubricates the joint. And it basically branches of several major nerves and blood vessels. So synovial fluid contains branches of several major nerves and blood vessels. All in all, this is very secured, in a sense, reinforced by ligaments, extracapsular and intercapsular ligaments. It contains nerves which can detect pain very easily. It's very sensitive nerves, and it is rich with blood supply. So that keeps all the tissue alive, as well as keeps on generating the synovial fluid. Typical example, say for example, say shoulder joint. If you look at the shoulder joint, you can see the shoulder joint contains, the humerus. As you can see, the head of the humerus and the glenoid cavity actually forms the basic shoulder joint. So this is the picture, the side view of the glenoid cavity. So you have this glenoid cavity. Just a moment, pointer. Yeah, so this is the red pointer, and this is the glenoid cavity. And the shallowness of this glenoid cavity can vary from one person to the other. So it is a hemispherical cavity over which the humeral head actually articulates. Okay, and this glenoid is part of the bone scapula, which actually slides over the posterior part of the rib cage. Okay, so this is the shoulder blade. We often call it the shoulder blade, and it forms the primary shoulder joint by articulating with the humeral head. And the other bone, which actually forms part of the shoulder joint, is the clavicle or the collarbone. The collarbone is actually articulating with another bony part which is originating from the scapula, and it is known as the scapular spine. Okay, and the region of that bone is known as the acromio. The acromio actually forms a joint with the clavicle and to give rise to the acromioclavicular joint. Okay, but there are several ligaments which holds the shoulder joint in place. But of course, it is a synovial joint in all respect, and it gives us the largest range of motion in the human body. No other joints provide us so much, range of motions as shoulder joint does. Okay. Now this is shoulder is from the upper limb, and if I consider knee joint, then that is another major joint in the lower limb. Okay. Now basically, if you see, let us just think that this in the upper limbs, if we consider the body into two halves, so there are the upper limbs, and which an example is a shoulder joint, and in the lower limb we have the hip and the knee joint. In the upper limb we have the shoulder and elbow. In the lower limb we have the hip and knee. Now you can easily understand that the shoulder joint combined with the elbow joint, they give us a huge range of motion. Okay. Whereas if you consider the knee joint and the hip joint, the range of motion offered by these joints are relatively less as compared to the upper limb joints. Okay. Now, there are two things here. This, as we had already discussed earlier, one of the major functions of bone is to provide stability. Okay, and it also, through its joints, articulating joints, it provides mobility. Now there is a balance between stability and mobility provided by different joints, particularly in the upper limb and in the lower limb. Okay, if you see the upper limbs, it provides more mobility to the joint, to the body. Okay, it provides for a person, the upper limbs provide more mobility, but it is less stable. If you move down the body, the lower limbs, hip or knee, actually provides more stability, and it carries more the body weight, and it is less mobile. So in the upper limbs, you have more mobility, less stability. In the lower limbs, you have more stability, less mobility. So in the knee joint, consider the knee joint. If you try to move your knee joint, it can only bend. Okay. So it more or less acts like a hinge joint. Okay. It has, although very small rotations about the other axis, but it is restricted to plus minus 5 degrees. Okay. So mostly the flexion and extension of the knee joint, the bending of the knee, is the primary motion that is arising out of the knee joint. So you can see here you have the distal part of the femur with the two condyles, the femoral condyles. One is basically the medial condyle and other is the lateral condyle. Now, how do I recognize which one is medial or lateral, or whether it is a left knee or a right knee? See the fibula, okay, the bone fibula, which is attached to the tibia. The fibula should be always outside. That means should be always on the lateral side, okay, not on the medial side. So if this is on the lateral side, so this, all these things are lateral condyle, this is medial condyle, okay, and you have the, so what is this? What is this? Is a picture of which? I just asked you. I have to put it on. Yeah.
Sir.
Yeah. So which knee is it? Right knee or left knee?
Right.
So it's a right knee.
Right knee. Because then, because the fibula should be always on the lateral side, outside. Okay, not towards the middle. Okay, so that's how you actually locate or sort of identify whether it is a right side or the left side of the located on the right side or the left side of the body from the picture or from the sample. Okay.
And sir, this is a view of the knee joint from the front or the back?
This is from the front, because you can see the front parts mostly, but it's not really front, it is a bit oblique, but this is basically, you are looking more from the front, but it is a right knee. That's the reason this is lateral and this is medial. The patella has to be in the front, remember. The patella is your kneecap. Okay, they've taken the patella, they've just taken it out, but this blue, just a moment for interruption. So this patella is actually, this should come up and seal this part in the front part. Okay. And of course, there is a strong ligament that is pushing the patella in and holding it in place to form the knee joint. So you have it's a typical example of the knee joint. So can I just switch on, put it on the, anybody has any question at this point? Hello?
Hello. Yes, sir.
What
Yeah.
is the function?
Yeah.
Sir, what is the function of patella?
Yeah, we will discuss it. We will actually visit. Yeah, can you hear me?
Yes, sir. Sir, I have
Yeah.
another question.
Yeah.
Sir, what is
just
the
let
difference
me.
between a
Yes.
so what is the difference between a cartilage and a bone?
Okay. Now, if we consider one by one, let me first answer the function of patella. Students, please be aware that now I am presenting an overview of the musculoskeletal system, right? But we will be visiting each and every joint, hip and knee from the lower limb, and shoulder and elbow from the upper limb. Okay, in detail. The biomechanics of there we would be discussing more in depth and each and every constituent element, function, as well as little bit of kinematics. So we will slowly enter, because as you can see, these questions are arising in your mind, because unless we understand the system biology, we are not going to, we cannot understand the subject more the kinematics and the kinetics of art. Okay, does that answer your question? Hello?
Yes, sir.
Yes, sir.
Yeah, so please be a little bit patient. We have to go in a systematic manner, and then you will get all the answers to your questions. Okay, but first, what you do, all the students, please fill up the Gmail address. I will include you during the weekend that share the Google Drive. Okay, and you need some sort of supporting study material. Okay, these are all uploaded in that folder, so it will help you to study. Okay, and the next question was what is the difference between cartilage and bone? Okay, now if we classify tissue, okay, when we classify tissue, we have actually two broad classification. One is hard tissue, one is soft tissue. Under the category of hard tissue, actually bone is categorized under the broad classification of hard tissue. Now, muscles, ligaments, tendons, cartilages, fibrocartilage, different hyaline cartilage, different sort of fibrous tissue, all fall under the category of soft tissue. Okay, so it is a tissue, connective tissue, but one is a hard tissue, another is a soft tissue. Okay, so there are two broad classification between the two, but each has its own function. The cartilage, which is you have seen the hyaline cartilage, the articulating cartilage. It's a very smooth and shiny surface for a normal person, and particularly for young people like you in the age group. The cartilage surface is very smooth and sort of shiny surface, and it is a sort of capping at the end of the opposing bones. So if people, people who are non-vegetarian, if you had been chewing some chicken bones, you would easily identify cartilage at the end of the, say, sort of the leg piece. Okay, isn't it? Hello?
Sir.
Yes.
Yes, sir.
Yeah, but
Yes, sir.
there is no reason of understanding cartilage by becoming a non-vegetarian from vegetarian. I don't insist on that, but you people who are vegetarian can remain vegetarian, but they can actually understand by categorizing it within the classification of a soft tissue. Okay, but sometimes the cartilage, the tissue, actually the grade of tissue can vary from one location to the other. Okay, sometimes it is, but a cartilage is always a cartilage. Okay, it can it can be a little bit more dense, it can be a little bit less dense, but a cartilage is always a cartilage. It's never bone. Okay, bone is a completely different type of tissue. It's a hard tissue. The density can vary. It has two different structures. One is a compact bone, a dense compact bone. Another is the trabecular or cancellous bone, and which is a porous network structure. So we will move into everything one by one, and maybe at the end, more towards the end, when we discuss about this tissue differentiation, then you will understand more that there is a clear division between cartilage formation, bone formation, mature bone formation, immature bone formation, and fibrous cartilage, fibrous tissue, different types of fibrous tissue. All the different types of cells actually contribute towards formation of these different kinds of tissue. Does that answer your question?
Yes, sir. Thank you.
Okay. So the more you move in the subject, it will answer your question more precisely. Okay. At this moment, let us get started with the musculoskeletal system, particularly from the point of view of a mechanical engineer. Okay. The relationship between structure and function. That is the primary objective. Okay. You look at everything from the point of view of a mechanical engineer. Okay. Now, let us get back to, just let me go to the other mode. Yeah. So let us get back to the knee joint. As you can see, the femur, distal part of the femur with the two condyles, lateral condyle and the medial condyle. You have at the tibia, the proximal part of the tibia with the two plateaus. Okay. One is the lateral plateau, another is the medial plateau. So this is the tibia, the proximal part of the tibia with the distal part of the femur is forming the knee joint. There is a very important bone which is known as the kneecap. More precisely, it is known as kneecap, but clinically it is known as the patella, which is, you can feel yourself if you put your fingers over the knee joint. The front part is your patella, and this patella is pushed inside the joint and it is held together by a strong ligament or tendon. Okay. Now there is another bone which is the fibula, you can see, which is located on the lateral side, and it is attached by some ligament to the proximal part of the tibia. Now, as you can see, the collateral ligaments on the two sides, so lateral collateral ligament, medial collateral ligaments holding the joint together. There is the cruciate ligament. The word cruciate actually originates from the word cross. Okay, so the cruciate ligament is a derivative of the word cross, and the anterior cruciate ligament and the posterior cruciate ligament, popularly known as ACL and PCL, are crisscrossing the knee joint and holding the bones together to form the knee joint. Okay, so these are the primary ligaments which actually is responsible for maintaining the stability of the knee joint. Apart from the cartilages, which are common in synovial fluid, in the knee joint there is another connective tissue sort of thing. This is known as the meniscus. Okay, so just note it, this is in the knee joint only. Okay, so you have a lateral meniscus and a medial meniscus, which is just on top of the proximal part of the on top of the tibial plateaus. Okay, and the role of the meniscus I will separately discuss when we will be visiting the knee joint precisely. Now, as I was telling you about the temporomandibular joint, these are slightly movable joints. Let me just go back to the where is it? Immovable, slightly movable joints. But I I did see the temporomandibular joint. Just a moment. Yeah, so temporomandibular joints, I was trying to explain you can see very clearly here, is a joint that is formed. It's a very complex joint, and it is actually connecting the mandible, which is the jaw. Okay, so you can see clearly here the mandible. If I focus here, this place, so you can see the mandible, which is the bony structure that on which the tooth is seated, and you have the temporal bone, and there you have a very complex TMG joint space, the blue one. Okay, and this is just on top of the mandible structure, which is hanging basically from the skull. It is connected with the skull through the temporomandibular joint here. So it has an articular disc and gliding. This is gliding above the disc. So it is, you can see when you open your jaw and then close your jaw, there is some gliding. It also has a hinge below the disc, and the movements that is offered from the temporomandibular joints are sort of, these are clinical terms, but what it actually means, we will explain you more in detail when we come across the movements. So it has depression, elevation, protraction, and retraction. So it is connected with opening and closing of the jaw, as well as some lateral movements. This much is enough at this moment. Yeah. Okay. Now, there are different types of synovial joints. So, as I have explained you that the anatomical joints has similarities with mechanical joints. Okay, and of course, the degrees of freedom it has. So when we compare the anatomical joints with the mechanical joints, it is always connected with the, wait a minute, just, oops. It is always connected with the degrees of freedom. So the anatomical joints has, there are several anatomical joints, as you all know, and the major joints, mechanical joints which are similar, or the anatomical joints which are similar to the joints, can be classified as planar joints, hinge joint, pivot joint, saddle joint, ball and socket joint, and condyloid or ellipsoid type of joint. Now, some examples I will present in the next slide. You can see the planar joints. So this is in the wrists. If you look at the wrists here, it's an example of a planar joint. Okay, there are, knee joint is a classical example of a hinge joint. As I told you, it is mostly rotation. There is rotation about the other axis, but very restrictive, plus minus 5 degrees. Only about the axis which passes from lateral medial direction, the gross rotation you get at the knee joint. Shoulder joint typically is a ball and socket, as you all know, and the hip joint as well. It's a ball and socket. And here are some of the examples where you can actually get to understand the similarities with the mechanical joints. The finger joints, and they are also they have similarity with condyloid joints. Now, hinge joint, as you all know, convex surfaces of bone fits in the concave surface of the second bone. And this is it's like a door hinge, and the examples are knee, elbow, ankle, and interphalangeal joints. Okay, and the movements they produce are flexion, extension, hyperextension. But this what are these things? What does it mean actually to you? These are new clinical terms: flexion, extension, hyperextension, whatever. We will actually just explain you a little bit later. Example of hinge joint. Planar joint, most surfaces are slightly curved, side-to-side movements only, rotations prevented by ligaments. These are salient features of the planar joint. Examples of planar joints are intercarpal, and the joints mostly at the wrist and sometimes at some finger joints. You can see the sternoclavicular joint. Okay, so if I go back a bit, look into the scapula, you can see the clavicle forms a joint with the acromion on one side, but the other side of the clavicle is actually forms a joint with the sternum. Okay, the other end of the clavicle, the collarbone. So you can feel yourself. The clavicle is a sort of a beam. It is connected on one side to the acromion on the shoulder, and the other side is at the sternum. Okay, which is near the neck. Okay, so that is a sternoclavicular joint forms. It's basically a planar joint. Now let us move to pivot joints. Now this is a classical example is the proximal radioulnar joint. You know the elbow, you have the radius, the bones radius, ulna, and the humerus. So the connection point between the radioulnar is the radioulnar joint, and that is a classical example of a pivot joint. Okay, you can see here the picture very clearly. So rounded surface of the bone articulates with the ring formed by the second bone and ligament. Okay, very clearly it is, the picture is presented. So, and it's a monoaxial since it only allows rotation around the longitudinal axis. So examples of the radioulnar joint. And these terms, supination, pronation, you will understand a little bit later. These are also movements, connected to movements. Saddle joint doesn't need too much of explanation because the picture is very clear. It is the shape of a saddle on a horse, and you can see the examples are typically the metacarpal of the thumb. Ball and socket, everybody can feel. Shoulder joint, hip joint. So examples are shoulder joint and hip joint. The ball fitting into a cup-like depression, a cavity. So it's a sort of a hemispherical cavity to sort of approximate with the spherical ball articulating will always give rise to rotations. So there would be flexion, extension. Flexion and extension are just opposite movements. Abduction and adduction are opposite movements. One is raising the arm, one is lowering the arm, so abduction and adduction. And grossly, it provides rotation about the three principal axes. Condylar joints, so again, examples are finger joints, so wrist and the finger joints. Oval shaped depression fits into another oval shaped depression. So this are an example of finger joints. Now comes, what are the factors that influence joint stability. Okay. Now, these are very important things that is connected with the mechanical system. If we consider the body as a mechanical system, so the factors that contribute towards the joint stability are as follows. Number one is the shape of the articular surface. So if the shape, say a shallow articular surface, can be a hindrance to the stability. For example, a shoulder joint. If the glenoid cavity is not deep, it is rather shallow, it will always result in, it is quite common in many normal person that the humeral head actually comes out of the glenoid socket. Okay, so the shape of the articular surface needs to be rather appropriate. It should appropriately fit with the other articulating bone, and it must not be too shallow so that it cannot provide sufficient stability to the joint. Okay, so the shape of the articular surface actually influence joint stability. The ligaments, of course, as you all know, function of the ligament is to provide stability to the joint. So ligaments unite bone and prevent excessive undesirable motion. Okay. Tendons connect muscles to bones. So tendons also are important stabilizing factor. Okay. So these three are the factors influencing typically a joint stability. Now, what are the disorders? As you all know, we all are mostly normal person, and we do a lot of activities throughout the day. But with time, there can be many joint diseases, particularly degenerative diseases, that can actually affect the joint, and which will actually result in disruption in your movement as well as a lot of pain. Okay, so pain and restrictive movements basically resulting in reduction of productivity and quality of life for people with damage to major joints. So these are typically joint disorders, and these actually affect the quality of life to a great extent. And these are common in hip, knee, shoulder, and elbow. Apart from these four joints, there are degenerative diseases set in also in the spine. Okay, in the lumbar spine, also sometimes in the cervical spine, and that is the vertebral column. And the lumbar spine actually takes into account a lot of compressive loads throughout the day due to different types of activities, and particularly when you are carrying a load. Okay, so bone degenerative diseases are also common. Apart from these four joints, are also common in the lumbar spine. Now, broadly, it has been observed through different all over the world. Particularly the advanced countries, maintain a very good documentation of through registry, the orthopedic registry, and it has been seen that the major disease that is affecting the world population is osteoarthritis. Osteoarthritis is a structural degeneration of the joint. Okay, you can see on the left a normal hip joint. You see how nicely the pink one is basically, we are trying to highlight the cartilage which is covering the hip joint, hip bone. Okay, the femur, and it is articulating in the acetabular cavity. So this is a normal hip joint. What happens in case of arthritic, which is affected by osteoarthritis? You have the cartilage surface worn out. So it takes a spiky pattern, irregular spiky pattern, as well as decreased joint space. So there is a space between the two articulating bones, which is known as the joint space. And this, there is a decrease in the joint space, and you can see the rough bone are exposed because the cartilage is worn away. The bone gets exposed, and sometimes it touches the other bone, giving rise to huge pain. So arthritic hip joint would look typically like this, with the degenerative nature of the cartilage and a decreased joint space. Arthritic knee, as you can see very clearly in the X-ray, the difference in the joint space between the left condyle and the right condyle. Okay, so this is the fibula. So obviously this part, this is the lateral part, this is the medial part. The lateral side of the knee joint is affected by arthritis, sort of osteoarthritis. So it is a bit tilted, and you can see how it is tilted. So this is increased joint space on the medial side, decreased joint space on the lateral side. Okay, so we have, so mostly we can say that osteoarthritis is a structural degenerative problem. And how can we rectify this? How can we offer new life and movement to the affected patients? Is in form of joint replacements, which are very common nowadays. So 75% of the patients affected by osteoarthritis undergo joint replacements. Okay. Apart from osteoarthritis, we have fractures. Fractures due to different reasons. It may be traumatic injuries, it may be a fall, maybe road accident, different types of things. So that actually have about 12% population is affected by fracture, which can be treated in different manners, because that is also another problem connected with the structure and function. Okay, typically you have femur neck fracture in elderly people, more elderly aged people. You also have trochanteric fracture, intertrochanteric fracture. So you have the greater trochanter and lesser trochanter. Within that, the fracture happens. And these are typically fractures that can be treated through fixation, but through plate fixation, through different kinds of fixation, but often in elderly patient, these sort of what can be applied to a relatively younger or middle-aged patient, depending on the bone quality. Some plate fixation or plate screw fixation that may not be possible in case of a aged patient. So at times they also, a hip fracture undergoes a hip replacement, particularly patients, more elderly patients, say more than 70 years old. But it is not also the age, it entirely depends on the bone quality. Okay, the decision to treat the patient in different ways depends on the quality of bone that is available for a particular patient. Rheumatoid arthritis is another arthritis which is very, very dangerous, and this is, as you might know, the rheumatoid arthritis is an autoimmune disease. So it is basically, it attacks your immune system and it causes a lot of destruction, degeneration of the bone, as well as the joint cavity. Here in the rheumatoid arthritis case, the synovial fluid is heavily affected. Okay, and there is swelling in the joint. The synovial fluid is affected. There is it needs complete replacements. But how many joints can you replace? It actually attacks your immunity system. It degenerates bone. So what happens is the bone becomes very porous, you have only a compact bone layer inside, within the bone structure. The trabecular structure of the bone degenerates, and it becomes very, very porous. So even a small, very slight stumbling can cause some fracture in the bone. Okay, so these are patients, very difficult patients to actually treat, and there is a lot of work still going on how to treat the rheumatoid patients, because they're very sensitive in nature. And generally others, for different other reasons, we have about 7% of the population which is affected by joint disorders. Now, there are two common things in the treatment of orthopedic surgery, is arthroscopy and arthroplasty. So what is the difference between arthroscopy and arthroplasty? Okay, arthroplasty is basically joint replacement. Okay, whereas arthroscopy is you are using some advanced technique to try to mend certain defects in the normal joint. So there is, you can see here in the picture that there is a camera that goes inside, and you can do some surgery using the arthroscope. Say there is some in the patella. This picture is from the patella. There is some spiky pattern in the patella, or some bony region gets a little bit irregular shape. That can be mended by doing some surgery. So instrument size pencil is used. Removal of, say, also torn knee cartilages, that can be removed. Something can be mended here in the normal to bring you back to the maximum normal condition, as you can imagine. Small incisions only. So you do the arthroscopy surgery. It is a surgery to actually mend some disorders that might have set in a joint. Okay, but arthroplasty is a completely different thing, and there is a lot of technology that is involved in the joint replacement. As you can see on the two pictures, one is typically a hip replacement, where you have a hip implant, the hip stem, and there's acetabular cavity. So you can see that in the hip bone, the upper part, the proximal part of the hip bone, that with the head and the neck, is completely resected and thrown away for a total joint replacement for the hip. There is another version available where it actually replaces the articular surface. So it is called hip resurfacing. Okay, that is less invasive. So it's minimally invasive. But in this case, in which is more common, is total joint replacement, total hip replacement. Part of particularly the proximal part of the hip bone, or the hip, the femur bone, is resected and thrown away. So total hip replaces acetabulum and head of the femur. So we have a socket and a metallic head. Now these materials are undergoing changes. There are new materials coming in, new designs coming in, to enhance the outcome of the surgery. So typically common is a knee replacement or a hip replacement. Now we have joint movements. As I was telling you, that we will get to know about the joint movements. You can see here what is flexion. So you raise your arm towards front of the body, is basically flexing your arm. So flexion and extension are just opposite movements. Okay, so you flex your knee like that, you flex your arm. So, and here extend is putting your arm towards the back, and when you straighten your knee, you are trying to extend your knee. So same thing with the head. So this is extension, this is flexion. So flexion means bending. Flexion means bending. You can see more figures with flexion and extension here. Now comes abduction and adduction, two opposite movements. Now, if you are raising your arm and you hold it there, say, just a moment. Do you understand the difference between, from the figure, do you understand the difference between the flexion extension and abduction adduction? It's in a different plane.
So it is bending backwards. Why are we still calling it extension? I mean, it is bending after all.
Yes. No, this is flex. So typically the movements are for the arm. You see, it's one type of movement. From the leg, it's slightly different. So that is how it is standardized. So flexion, when you say flexion, means bending more bending. So towards the front, if you move your arm, we are calling it flexing of the arm. When you move it back, we are actually extending the muscles. If you feel yourself that you are more extending the muscles. Okay? That's the reason it is called extension. Similarly, when you do it for the leg, you see when you bend your knee, that means you're flexing your knee. Okay? So in this case, you have, say, about 90-degree flexion. But when you straighten your knee more, then you are extending your muscles more. Okay, so that's the reason it's called extension. Okay, but abduction, adduction is you're raising your arm, but in a different plane. Okay, so if you look from the front, you can raise your arm and hold it at a 90-degree position, and that is 90-degree abduction. You can actually put your arm straight up beside your head, and that is 180-degree abduction. If you lower your arm, then it is the opposite, that is called adduction. Okay? Any questions? Hello? Hello? Can everybody hear?
Yes, sir.
Yes,
Yeah.
sir.
So is it clear from the figure? So please study the figure. We can discuss it more, but let me move on with the lecture, and then we can get on with the discussion a little bit later. Okay? Is that okay for everybody?
Yes, sir.
Okay, sir.
Yes, sir.
Just a moment. Now you have other sort of movements in form of rotations, like you are rotating your head. So that is rotation. You can have lateral rotation, that is rotation towards away from the body. You have medial rotation, more rotation towards the midline of the body. Now special movements of the hands and feet, as I was telling you, the terms say pronation, supination. Okay. Dorsiflexion, plantar flexion. So these are movements, special movements of the hands and feet. Okay. So if you visit these figures, you can understand very easily what is meant by these sort of movements, pronation and supination. So if you say show your palm and the elbow joint, so one is pronation is towards, it's moving, radius rotates over ulna. So pronation, for pronation, the radius is rotating over the ulna. Okay? And for the supination, the radius and ulna are parallel. Okay? So this you have to try to understand. So there are two movements, opposite movements, pronation and supination, but this is mostly connected with the elbow. Okay? Eversion and inversion refers to movements that tilt the sole of the feet away from the eversion or towards the midline of the body. So one is towards the midline of the body, one is away from the midline of the body. These are things that we often do as exercises. As far as I remember, once upon a time I used to play very active cricket, and we used to warm up doing many exercises that actually activates these sort of movements. Isn't it? Now, a very basic movement. A very important and a basic movement of human body is normal walking. And that is typically showcased as the gait cycle. So why we call it a cycle? Gait means normal walking, and a cycle means that it is repetitive in nature. It's periodic and repetitive in nature. So a typical gait cycle is shown here. As you can see, that it consists of two phases. One is the stance phase, another is the swing phase. Okay. Now there are two legs are taking part in the whole gait cycle, and you have to very be focused in identifying that which leg is doing what sort of movement. When one leg is actually undergoing stance phase, the other leg is going through the swing phase. So it is together, in conjunction, they are actually not only offering you movement, but also supporting the body weight. Okay, so you have in this picture, so what we do, the first step, if we see the right leg, which is black here, it comes in contact with the floor through heel contact. So our heel strikes first. Okay, so this is the point where heel strike occurs. First point. What is the last point of the gait cycle? The same leg again strikes the ground. So that completes one full gait cycle. So a cycle has to be repetitive in nature. So it starts with heel strike, and then the next instant is the foot flat. So after you strike the ground with your heel, then your whole right leg is the foot becomes flat. And you see the change in the left leg, which is white. Okay, so there is a mid stance phase where actually there is double support. You see that the double support is here as well. Up to, so there is a mid stance phase, so foot flat, and the left leg is actually swings and comes in the mid stance phase. So when the right leg is actually executing the stance phase, the left leg is swinging and coming and supporting it. So the right leg, this is the mid stance, then the heel goes off. The heel takes off from the ground, and then the toe goes off. So this is basically the stance phase. After that, there is the swing phase where the actually the right leg has gone behind. It swings and comes in the mid swing and later comes and contact the floor at heel strike. So if you look at the different phases as I have reported here, there's the right and the left is shown very clearly. So the right leg is the right stance phase and the right swing phase. And this is where it is, each instantaneous point is marked in the gait cycle. So when it is undergoing, when the right leg is going through the stance phase, the left leg is going through the swing phase. And when the right leg is going through the swing phase, the left leg is undergoing the stance phase. Okay, so you have to look into this gait cycle. We will discuss it more again because there is a lot of kinematics involved in this. There's a lot of forces of the muscles, the joints that we will discuss, and we will also calculate. So, but a very important part of the topic of biomechanics is a typical gait cycle with the different phases as presented in the figure. Oops. It's not moving. Oops. Yeah. Now, a little bit more about the gait cycle. As you can see that the different percentages. So when you go through, so initially there is double support, then right single support. So from 0% to 15% is double support. And from 15% to 45% of the cycle, it is right single support. So the right leg is more active in the whole walking cycle. Then you have 45 to 60% of the gait cycle, you have a double support. Okay. Then left single support, the left leg takes more load up to 100%. So you have right stance phase and right swing phase, and just the opposite, the left swing phase and the left stance phase. So in total, with the percentage of cycles very clearly indicated, you are actually, this is the whole gait cycle can be figured out in a more quantitative manner. And thank you for listening. We can have questionnaire session now. Yes. Okay. Any questions?
So the right single support period is a different percent of the upper cycle and a different percent of the lower cycle. Could you please explain that once again? In the last slide.
Can I, then I have to share the content. Yeah.
This, yes, sir. Over
This
here
one.
in the right single support period, it starts
Right
from
single.
15% of the upper cycle and goes up to 45% of the upper cycle, and starts at 0% of the lower cycle but goes up to 40% of the lower cycle.
No, not lower cycle, not upper lower. It's left and right.
Okay, yeah. So it's totally 30% of the right cycle and 40% of the left cycle. So is that how it should be?
Just a moment. You have the right leg executing the right single support, right?
Yes, sir.
From 15 to 45%.
Yes, sir.
But you see the left swing phase actually starts with a lag. Okay, so initially this is where, if I just go to the earlier slide, see, it starts from heel contact. Okay, the heel strike. Heel strike to toe off is basically your, say, if you concentrate on the right leg, then heel strike to toe off is your first right stance phase. Okay, right stance phase. Now, if I look into the other next figure, so right, this is the initial contact. This is where the heel strike starts. Okay, just a moment, let me put it in there. So this is where the heel strike starts. Then you have a phase of a small double support, 15 up to 15%. Then you have the right single support, because it is here the left leg is swinging, so left leg is hardly supporting your body weight. Okay, so the left swing phase starts actually with a little lag. So the stance phase is 60% and the right swing phase is 40%. If you see here, the left swing phase is 40% and the left stance phase is 60%. That makes it totally 100%. But there is a slight lag in between the right and the left leg. But in total, it is 100%. Is it clear?
So what I meant to ask is, doesn't the right single support phase coincide with the left swing phase?
Yes, it does. Oh, you
So
mean
the
that?
right, so the
Okay,
right
okay.
single support phase constitutes only 30% of the right cycle, and the left swing phase constitutes 40% of the left cycle. So that's where I was getting the doubt.
Yeah, but there is a little lag here. So in the left swing phase ideally is 40%, right? And the right, you see, this is the stance phase. If you broadly classify the stance phase and the swing phase, it is 60-40 for both the legs. But within the stance phase, you have several phases like double support, right single support, and a double support again. Okay. So when you are comparing, you should compare stance phase with stance phase. Okay. So the right single support phase is 30% of the total stance phase of the right. Is that clear?
So, sir, that means that the right single support phase is less than the left swing phase.
No. Single support, see, swing phase is 40% for both the cases.
But single support is 30% for both the cases.
Single support is 30 for the right single support, it is 30%, and for the left single support it is more, 40%. No, it is 30% for the left leg. For the left leg, from 55% to 85%, that is 30%.
Sir, this is where the problem is arising. Sir, 30% of the right cycle is equal to 40% of the left cycle. If we look at the margins correctly, like the lines correctly, like if they coincide.
Yeah, that is something which needs a little bit more attention. I will have a look, but see, when you if you look at the left leg, when the single support, the left single support, here it is marked as 55 to 85%. That means 30%. Okay. Similarly, if you look at the right single support, it is marked 15% to 45%. That is again 30%. Okay, but if you look at the swing phase and the stance phase, then the total stance phase of each, left or right, is 60% and 40% for the swing phase. I think the figure is little bit, as you said, is little bit confusing because they are trying to put many things together. Hello? Hello?
Yes, sir.
But essentially, if you look that the right single support or the left single support, I think this is little bit confusing here. This is 60, this is 40. This is 60, this is 100. So they actually, this is meant for the right swing phase. So that is 60 to 100%. The right swing phase is 40% of the whole cycle. But if you look at single support, left single support, it comes to 55, starts from 55% to 85%. That is left single support. I think this number should have gone a little bit higher. The left single support is from 55% of the cycle to 85% of the cycle. Otherwise, it doesn't match, as you said.
So that's what I was saying. Whatever it is, it should be the same for both cycles.
Yes, it should be the same for both cycles, and then you can see the lag between left and right, and that's the reason the whole, the double support phase actually is there is a lag of the left. I mean, if you consider the right heel strike, it starts from the left side from 0, but there is a lag here for the left leg, which is actually made up later. See, because it's a cycle, so it has to go back to the originating position. But I think this marking, this 0, 15, 45, this is primarily for the right stance phase, right leg. This is little confusing. I understand. The left leg, where it is marked 55 to 85, at the same time it is saying 60 to 100. See, this extra 15% comes later on for the left leg. Hello?
Yes, sir. The double support region is not the issue. It's only the right single support and the left single support, which constitute varying percentages of the left cycle and the right cycle. That's actually causing the confusion.
Yeah, but the right swing phase is definitely the 40%.
Sir, if we look at like this,
yes.
Hello. Sir, if we look at it like this, just considering the right cycle, it has 2 double support phases and 2 single support phases, which are identical to each other because the left and the right legs are identical to each other.
Yes.
So one double support plus one single support should constitute 50% of the cycle. But as they have shown, it's only constituting 45 in one case and 55 in the other case. It should be half exactly.
No, yeah, but this is see, there is a lag also between the left and the right.
Sir, if we remove the left cycle from the picture for a moment, the right cycle is basically should be divided exactly in half at the point where the right single support ends, right? Because the 2 parts are identical. One double support and one single.
There is some, there is a phase. There is a fuzzy area here between 45 to 60.
Sir, so both the double support phases are not identical to each other. Like they should be. Like they're saying that
Exactly.
they are 15% each.
There is a fuzzier, because you see, when you walk, you try to understand when you walk. There is when it is double support, how much it is taking. That we will understand later on when we go into the kinematic analysis. Also, there is a very important website which we'll get access to data, real data. Then we can actually have a more in-depth when we go in sort of instantaneous data. Okay, but definitely there in this double support region, what you say is between 45 to 60, and here it is, this is 15%, right? Here on the left case, it is also 15%, 40 to 55. But what you said, that whether or not this is exactly 50%, that is difficult to say. Because this double support phase is a bit fuzzy, because both the legs are taking part, and it's sort of what percentage is of weight it is carrying. These are different things that is difficult to have to sort of gauge unless and until we have clear-cut measurements. It's sort of it is sort of approximate things. I have seen data where they say 13% you get, say, when you're walking. In case of, say, hip joint, if you consider the hip joint force, the peak force is occurring at 13% of the gait cycle. Okay, so, but yeah, let us have more, thought about this. You can start investigating, look into papers on gait analysis. Okay, this is what I want. So taking part in the class, more discussions. This is how you learn more, on research-based subjects. It should evoke the right questions. Okay, so gait analysis is a highly technical subject, and it is a set of complex events with the two legs actually taking part in tandem. Okay, so I would appreciate more discussion on this. Maybe we can have it in the next class. Hello? Hello?
Yes,
Can
sir.
you hear?
Yes,
So you already have some time, and you can look into papers and on the basic stuff of gait cycle. But first, let me put you on the access to some material, the basic textbook. Okay, there is a textbook by Nordin and Frankel, and when you open this Mechanics of Human Body folder, you will see a lot of lectures, questions of earlier years, and also books and papers. Okay, so the Nordin and Frankel book, N-O-R-D, I'll just write it for everybody in the chat box. Oops. Okay, you will find the electronic version of the book. You can visit that, the gait analysis, and Of course, I would appreciate, you can take it as an assignment if you like. Okay. So this is very early stages, but we can convert it into an assignment if everybody agrees. Can everybody hear me?
Yes, sir.
I'm stopping recording.